We will invite the next lecture, dear Professor Robert Fronzo. He will talk about treatment of diabetes, straight to fall or to succeed.
Okay, I guess I'm back for the fourth or fifth time. I've lost track. So this is an easy talk to give because we will never fail because we have the drugs that are necessary to treat people. You just need to use them. And so I'm going to start in a funny way. I'm going to start with what does not work, okay? So if you learn this message, you will always fail. So this is a very simple message to give. So I'm just going to take you back to the United Kingdom prospective diabetes study because we've known for 30 years what does not work. So Dr. Robert Turner, when he started a UK PBS study, really believed that you could take individuals, put them on a single oral agent. Remember, at that time there were only two, metformin and sulfonylureas, and you would put them in that oral agent, the A1C would come down, and it would stay down for the rest of your life. So he took newly diagnosed diabetic patients, starting with an A1C of 7, and there were 4,200 people in this study, and he divided them into 3 groups. One group got diet and exercise, that's the yellow group, and you can see that they didn't do very well. In fact, there was a progressive rise in A1C, which he showed was all due to progressive beta cell failure. A second group got treated with benclamide, a sulfonylurea, works very well initially, kicks out insulin, overcomes the insulin resistance, A1C comes down, but you can see no durable effect with the sulfonylurea. What about metformin? Metformin has one action, it works on the liver, shuts down gluconeogenesis, hepatic glucose production falls overnight, fasting glucose falls, A1C initially comes down, but again you see progressive rise in the A1C because no effect on the beta cell. Now, obviously, each one of these curves has a plus-minus standard deviation, so to speak. So if we were to look at metformin, there clearly are going to be some people who respond well. There are going to be some people who respond very poorly, but on mean, this is the curve that you're going to get. So you may have in your practice some people who actually respond reasonably well to metformin or sulfonylureas. In some of the kiddie cases, actually they should be on a sulfonylurea, this is a specific indication. But in adults, in general, this is what you're going to see. So if you want to fail, use these drugs, okay? And what Dr. Turner noted was that 5 years into the study, the A1C had now risen to baseline, and he wrote 5 articles: Diabetes, Diabetes Cure, Diabetologia, BMJ, and Lancet. And what he said is, my hypothesis is not correct. I can't put people on one of these agents, keep the A1C down. So if you're on a sulfonylurea, add metformin. If you're on metformin, add sulfonylurea. And then he said, if necessary, I will add insulin. So what happened 15 years later? 15 years later, everybody's on both oral agents. 65% of the people are on insulin, and the A1C is 8.6. Had nothing to do with this study. I just looked at the results. That is failure, okay? And if you want your patients to fail, this is what you're going to see. And in fact, this has pretty much been reproduced with every study that's looked at metformin and sulfonylureas after Dr. Turner. But this was a major breakthrough at this time because there was a lot of discussion as to whether glycemic control made a difference. And what he showed was this 1% difference in A1C decreased eye, kidney, and nerve complications by 37%. So it was a landmark study in two ways. Number one, it showed the importance of good glycemic control, and quite frankly, retrospectively, it told us what was going to work and what was not going to work, although that, of course, was not the purpose of the study at this time. What he really hoped is the A1C would come down to 6, stay down, we would eliminate all of the burden of hyperglycemia and obliterate the microvascular complications. So here's now a very different picture with the thiazolidine downs. And in fact, you heard several times throughout this meeting, there's kind of a resurgence. Resurgence is the best drug in the world for treating NASH. It was said, but not said emphatically enough. Very different picture. A1C comes down and it stays down. And when we saw this, and I made this point earlier, if you want to know what's happening to beta cell function, just measure the A1C. If the A1C is rising, your beta cells are failing. If the A1C comes down and stays down, the drug is working. So we all know that this class of drugs are good insulin sensitizers. These are a series of insulin clamps done in several hundred people with pioglitazone and rosiglitazone. And as you can see from the heights of the bars, if you look at insulin-mediated glucose metabolism, there's about a 35 to 40% increase. But when we saw that A1C come down and stay down, we knew this had to be due to an effect on the beta cell, which is really not very well appreciated. So this is a study that Dr. Amalia Gastadelli and I did, where we took people who were drug naive, the first 3 double sets of bars, and we gave an OGTT to them, and from the OGTT, we could measure the insulin secretory rate, and we expressed the insulin secretory rate, the increment during the OGTT, for the increment in glucose, and on a separate day, we did an insulin clamp to measure their insulin resistance. So if you got placebo in yellow, you can see nothing happened to your beta cell function. And this is the gold standard for beta cell function. If you got pioglitazone in green, I tripled your beta cell function. If you got rosiglitazone in the light blue, I increased your beta cell function 2.5-fold. And then we said, well, what happens if you had your disease for 10 years and you're on a sulfonylurea? And presumably you had less beta cell function. Well, if you can see in pink, the placebo did nothing, and in orange, we still got a doubling of your beta cell function. So the DCDs correct 2 of the basic defects, insulin resistance and beta cell failure, and that's why we like them. And when I say we, I mean Mohammed and I, like these drugs very well in the treatment of type 2 diabetes. Now what about the incretins? There are 2 of them, GLP-1 and GIP, and these 2 incretin hormones account for 60 to 70% of the insulin that you secrete in response to a meal. And if I were to knock out either GLP-1 or GIP, and you can do this because there are now antibodies to the receptor, I instantaneously make you a type 2 diabetic. It shows you how critical these 2 incretin hormones are in maintaining normal glucose homeostasis. And we have a wide variety of these incretin hormones. The first one, of course, was Byetta, the short-acting, you give it twice a day. Same lixazanazide, which is further down on the list. Then came liraglutide, which is once a day, then a number of once-weekly ones, exenatide, Bydureon, albaglutide, which really is not around anymore, dulaglutide, and then more recently, and I understand this has recently been introduced in this area, semaglutide, and we have an oral semaglutide that's in development that looks pretty good, and then we have a little osmotic mini pump that can be implanted under the skin that releases exenatide over a period of 6 months. So lots on the market and lots more to come. So I showed this slide earlier, so repetition for some of you here in the audience. These drugs have an incredibly powerful effect that I'm going to show you to improve beta cell function And in doing so, you get a very nice, gratifying drop in the A1C that stays down as long as you're on the drug. These drugs make you lose weight. When you lose weight, you improve the insulin resistance. You also get rid of lipotoxicity in the beta cell. Further helps to improve the beta cell function. They correct 6 of the 8 abnormalities in the ominous octet. I'm not going to take you through all of those because I did it earlier today. They do not cause hypoglycemia because when the glucose comes down to baseline, you stop secreting insulin. So as long as you're not using with a sulfonylurea, you don't have to worry about hypoglycemia. They're incredibly safe except for the GI side effects. So there is always going to be 2 or 3% of people who cannot tolerate the drug. On the other hand, we have other drugs that you can use, and then we have this remarkable cardiovascular story that I will touch upon briefly, that these drugs prevent recurrent cardiovascular events. So I directed all of the initial studies with Byetta, which is the first one to come, and so all of the studies were done the same way. I'm going to show you a meta-analysis of all of the studies submitted to the FDA that got this drug approved. So during the first 30 weeks, people are going to get placebo in yellow or the Byetta in orange. Starting with an A1C of 8, you see a drop in A1C of about 1 to 1.2%. Placebo does nothing. At 30 weeks, I take the placebo people and now I give them the Byetta. You see a very nice drop in A1C. The people are on the Byetta, stay on the Byetta, orange line stays down, and now we have the 3.5-year data. A1C comes down and it stays down, can only happen because of one reason. What is the reason? Beta cell function. In unison, what is the reason? Everybody. I stop talking unless I get an answer from everybody's mouth. I heard a few beta cell function improved. I need to hear it from everybody. Okay, now I can continue. Because that's the most important message that I can give to you today, okay? Control of the A1C is critically dependent on what happens to your beta cell function. If the A1C comes down, it stays down, you're doing the right thing. If A1C is rising, you're losing the game with the beta cell, okay? So there's a very simple way in which you can measure beta cell function. It goes beyond the difficult ones that I talked to you about earlier. This is called the graded glucose infusion of Polanski. I'm simply going to plug in an IV, and I'm going to raise your glucose concentration from normal here, and I'm going to raise it up to about 200 to 300. And when you do that, and I can measure the insulin and C-peptide that comes out, I calculate the insulin secretory rate, and you can see it goes up at about a 45-degree angle. That's normal glucose tolerant individuals. Here now is what happens when you do this study in diabetics. Very blunted rise. The diabetic beta cell is blind to glucose. This is the characteristic lesion. Now, this is what I call the Chang study. This is the most important study done, in my opinion, in the diabetes literature in the last 10 to 15 years. If I had 100 endocrinologists in a room and I asked you what the Chang study was, it would be lucky if one person raised their hand. But I just told you this is the most important study done in the last 10 to 15 years. It is published in Diabetes. So why don't endocrinologists know it? Because now I'm going to show you a miracle. I'm going to give you 1 injection of liraglutide. The dose is 0.75 milligrams. So remember, we start at 0.6, then we go to 1.2, we go to 1.8. 1 injection, 8 years later, here's the miracle. I just gave you a normal beta cell. Why wouldn't you use that drug? So you could say, oh, it doesn't happen with anything else. Well, now I'm going to show you what happens with semaglutide. Same study, but this is a 3-month study. So the NGT controls, okay, I treat you with semaglutide, and then I do this graded glucose infusion test 3 months later, and you see the very nice rise in beta cell, and that's in the normal glucose tolerant individuals being treated with placebo, so they're getting nothing. I do this in the diabetics, getting placebo, and you see the same low rise, they're blind. Now I'm going to treat you for 3 months with semaglutide, I just gave you a normal beta cell. And I'm not going to show you, because of redundancy in time, exenatide 3-year data. So I've now shown you 3 different GLP-1 receptor agonists, 1 day, 3 months, 3 years. You think there's any different from any of these other ones? These drugs acutely, very acutely, in a long-term basis, and Mohammed and I have data which we're putting together now, up to 6 years, but in our study we're combining with pioglitazone, maintaining the beta cell function. Now, if I can go back, oh, darn it all. Okay, so most recently, I know we've had semaglutide for a while, but my understanding is most recently it's also been introduced to this area. So this is the head study with semaglutide with Trulicity. And there are 2 doses, a low dose and a high dose. So these are the low doses to the left, and we're going to look at A1C over here. So the dulaglutide is in yellow, the semaglutide is in orange. For the low dose, 0.5 and 0.75. And you can see very clear here that the semaglutide beats the dulaglutide. If you look at the higher dose, again, the same thing. Semaglutide beats dulaglutide. Now, if we look at body weight, both drugs are very good in losing body weight, but again, semaglutide is the more potent one, 4 kilos versus 2, and at the higher dose, the same. But we're seeing big differences between these drugs. So how would I classify the GLP-1 receptor agonist? The worst drug in this group is a fantastic drug. The next best drug is a phenomenal drug. The next best is an out-of-planet one. And the next best one, which is the Lilly drug, which is coming, is an out-of-universe drug. You cannot go wrong. And the message is here, put your patient on any one. I'll be happy, okay? Now, if you happen to have semaglutide here, that's great. But if you don't, and you have Bydureon or Trulicity or whatever one you have, I will go for it. Now, what about DPP-4 inhibitors? Here is a very different story. If you look at the drop in A1C, whether you're using in drug-naive patients as we go across glyburide or metformin or far right in orange pioglitazone, the drops in A1C are in the order of 0.6 to 0.7. Close to 1/2 of what you're going to get with the GLP-1 receptor agonist, no weight loss, and the cardiovascular studies with these drugs are all negative, as opposed with the GLP-1 receptor agonists, which are all positive. Another big reason for using the GLP-1 receptor agonist over the DPP-4 inhibitors. Now, what about the SGLT2 inhibitors? The 3 big ones are shown here, dapagliflozin, canagliflozin, and empagliflozin, but there are several other ones that we have in the United States, and in fact, we heard a lecture earlier about ertugliflozin, the Merck one. Sanofi has another one. In my opinion, and I said this before, these drugs are all very good and equally good. So I wouldn't say that any one drug in this class is better than any other one. What you're going to put your patient on is probably affordability and access to the drug. They're all going to do very good things in terms of glycemic control. So they have a novel mechanism of action. They work on the kidney. They block glucose reabsorption by the SGLT2 transporter. So you excrete 70, 80, 90 grams of glucose every day in the urine. As now the glucose comes down, you remove the glucotoxic effect on the beta cell, so you improve beta cell function. You remove the glucotoxic effect on the muscle, so you improve insulin sensitivity. Nice reduction in A1C. Because you're losing calories in the urine, these people usually lose about 2 to 3 kilograms of weight in the first 6 months. And because they're working on the kidney, and they work differently in a different organ from all the other drugs, you can put them together and get a completely additive effect. And actually, in studies that we've done, when you put them with a GLP-1 receptor agonist, at least on body weight, you get a synergistic effect. So in a study with liraglutide, that I'm not going to take you through, but it's published, the liraglutide, you lost about 3 kilos. The SGLT2 inhibitor, 3 kilos, and together you lost 9 kilograms of weight loss, which is really quite significant. They reduced the blood pressure because they block glucose with sodium transport. You get a decrease in the intravascular volume, nice decrease in blood pressure, no hypoglycemia, and because of all of these mechanisms of action, not only do you get good glycemic control, but you would expect to get cardiovascular protection. And in fact, I've shown you data, and we've seen other data from other people here, that all three of the first 3 drugs out there, canagliflozin, empagliflozin, and dapagliflozin, all decrease the MACE endpoint, hospitalization for heart failure, and they also give you renal protection. So how can you use the SGLT2 inhibitors? Just like the GLP-1 receptor agonists, they can be used as first-line therapy. They can be used as add-on to metformin or any of the other agents that your patients might be on. You can add them in combination. Mohammed and I like to do this from the beginning. We particularly like pioglitazone with the SGLT2 inhibitors. We also like triple therapy, and the third one can be a GLP-1 receptor agonist or metformin. You can add it to insulin in type 2s. There's a lot of discussion about adding it to type 1, approved in Europe, but not in the US, and studies that are ongoing looking in the pre-diabetic. So really the whole broad range of individuals in your patient population would be potential candidates for this therapy, and they are particularly effective with a high A1C. The higher the glucose, the more glucose you're going to dump out in the urine. Now, this is the treat to fail story. This has been what the American Diabetes Association and the European Diabetes Association has recommended, well, until literally last year. And this is what Dr. Turner showed you should not do, okay? So you start diet and exercise and drug number 1, which is usually metformin. And yes, you get a nice drop in the A1C, but then it rises again. And then you add the sulfonylurea drug, and you get a nice drop in the A1C, and it rises, and then you add the DPP-4 inhibitor drug, because it really doesn't do much to beta cell function, you fail. So this is the treat to fail. Rather than putting on people on drugs to treat to succeed, you're guaranteed to fail. Now, this you cannot probably read. This is the ADOPT study by Stephen Kahn, okay? This is the reproduction, okay, in modern day history of what Dr. Turner did. It took him 20 years later to repeat Dr. Turner's study. And you know what happened? He found exactly the same results. Of course, this same drug hasn't changed in the last 20 or 30 years. And we haven't seen any new miracle mechanism of action from these drugs. So we believe that a more rational approach is, in addition to lifestyle, which of course has to be the baseline therapy, is triple combination. And the initial study that we started is with pioglitazone, metformin, and a GLP-1 receptor agonist, exenatide, and I'm going to show you some of the data from that. Quite frankly, if we had to do this study again, we would probably use the SGLT2 inhibitor instead of metformin. It just was not available when we started the study. And we think the goal for therapy should be less than 5. So right now, there's a dichotomy. The ADA diagnostic goal is 7, okay? The ADA treatment goal is 7, but the diagnostic goal is 6.5. So we believe that if you establish a disease, that it should be treated, and that the treatment goal and the diagnostic goal should be synonymous, and at least for the ADA, they're not. So in this triple therapy study, we had 155 drug-naive patients, and they were randomized to the triple therapy, which was starting right from the beginning with exenatide, pioglitazone, and metformin, and compared that to the ADA approach was start with metformin. When you fail, add SU. When you fail, add insulin. You can tell these are San Antonio patients. BMI is 36. We consider this to be lean in San Antonio, okay? I recently come back with China, and the epidemic of diabetes in China is now being driven by obesity, okay? It's no longer beta cell failure. And you know what their idea of obesity is? A BMI of 25. Because in the previous years, it's been 19 to 20. So people who have a BMI of 25 are really considered to be fat and looked at in a very negative way. And that's what's driving the obesity epidemic. Believe me, I'd love to have all my patients have a BMI of 25, but I guarantee you it ain't gonna happen in San Antonio. And duration of diabetes here you can see is about 5 months. Starting A1C is 8.8, but we took all comers from 6.5 up to over 14. So what happened in this study? You can see initially with both groups, there's a very nice drop in the A1C, but here at about 4 to 6 months, now the curves start to separate. So the conventional therapy at the end of 3 years, they're at about 6.7, and with the triple therapy, it's about 5.8. So this is close to a 1% difference. At this level of A1C, this is a huge difference, okay? And if we now look at the Kaplan-Meier plot of time to failure, meaning an A1C above 6.5, you can see in the triple therapy group, there's about a 10 to 12% failure at the beginning, but then this stays pretty flat. And if you look at the ADA old approach, you can see this is going down progressively with no indication that this is going to parallel off. So what is the reason for this? So in this study, we measured insulin sensitivity using the Matsuda index during the OGTT. Severely insulin resistant at baseline, no change at 3 years. Here's beta cell, here's with the triple therapy approach that we use, an enormous improvement in insulin sensitivity. What about beta cell function? Severe loss of beta cell function before, no improvement with the ADA approach, almost normalization of beta cell function with the triple therapy approach. Here now are the 6-year data, and you see that this persists, this difference in A1C after 6 years. But what you need to remember is that a lot of these people have already failed, and we're titrating the insulin dose up, which makes the A1C look better in this group, even though they failed because failure meant you had to be on 60 units of insulin or more. And then you see the Kaplan-Meier plot of time to failure, and it's continuing on with really no indication that this is going to level off. So where do we stand now with SGLT2 inhibitors? Because when we started this study, they were not available. So I would say you can put them and match them any way you want. So you can take the SGLT2 inhibitor, you can combine it with metformin or pioglitazone, and the GLP-1 receptor agonist would be the third. And you can mix and match these any way, shape, or form that you want. You all feel more comfortable with one drug or the other, so you can pretty much choose how you would like to put them together. We can't test every combination, someone else will do it, but I'm quite certain that 2 or 3 drugs together, this combination on a long-term basis, is going to be very effective. So the conclusion is combination therapy works as long as one uses the medications that I told you correct the underlying basic pathophysiologic defects. Thank you very much for your attention.
Thank you, Professor De Fronzo. The next speaker,